Hello, dear colleagues. My name is Hajto. I'm from Munich, Germany, and I'm glad to be able to help Adam Nalty with his project to ship some 3D printed parts to healthcare providers in these hard times. So today I want to talk a bit about comprehensive dentistry, and let's see what's that about. But first, a few words about myself. I'm a dentist in his own practice. I'm not working at the university, and I'm a specialist for aesthetic dentistry, so mainly I do prosthodontic work, fixed restorations on teeth and implants, and I work over 15 years purely with all ceramic materials, and yeah, that's my main field of expertise. So my personal development, let's have a short look at that. The bottom line is I was always developing and learning. So if you think you're already a good dentist, you should ask that yourself a few years later. In the beginning, I thought I can do quite a lot and I'm good at what I'm doing. After a few years, after I left university in '93, and then a few years later I realized that really wasn't so good. I still improved a lot of things I didn't know about. And that process continues actually, I think, a lifetime if you try to be a good dentist. So I didn't learn about aesthetics or function in the university. I learned the basics that you need to know to be able to treat teeth. But aesthetics, dental aesthetics wasn't taught at our university, and the whole area of function neither. So that came in the years when I worked in my practice. First, I taught myself aesthetics. At that time there weren't many books, so I'm a little bit self-taught. I went to the masters then that existed there, and actually all the knowledge I put together I put down in 2 books, the Interiores books, about which you might have heard already. And then I also quite early started teaching, giving courses, trying to pass on what I've learned and what I was getting more and more good at. And after in aesthetics there was nothing more to learn, because that's one characteristic of dental aesthetics. It's a closed field. If you put enough effort and energy into it, you after some time you know everything that is to know. And then I discovered that there are also functional cases that if I do the same thing with my tooth-colored materials in different patients, in one patient it works perfectly, in another patient it doesn't. So what's the reason? Obviously there are some differences in the stomatognetic system, how it works, the loads, the functional patterns, and that became more and more important then in the next 10 years, and I tried to learn everything I could about that and implement it always in a practice concept that I can use in my daily work. I think in the end it only counts what you can put to a good use for your patients, and not learn and keep in your head or forget again or try it once or twice and then don't practice it anymore. Always see where the real value is, that you can give your patients some benefit and you can use it like almost every day in your own practice. And after that was quite mastered, I would say, or under control, then I realized this is also not complete dentistry. There's also an office to run, and today this is the area that interests me most: practice management, how to also run a good office with good employees, happy patients, and not only thinking about teeth. So that is what I'm teaching these days, and I give courses on practice management and how you can improve your numbers and all these things. This happens only in Germany. The other courses on aesthetics and function I do also internationally in English, but I think the situation in different countries is sometimes comparable but not the same, so I can quite well tell German dentists what they can improve. I'm not sure I could do that also in other countries. Last year I wrote a book about good dentistry. It's in the Quintessence publisher. Unfortunately not yet translated. I hope that it will be translated in other languages as well. But that is the quintessence of what I'm always thinking for many, many years. What is a good dentist? What makes good dentistry? And it's a little bit philosophical, a small book. So in case you understand German, you might want to have a look at that. So let's start by the basics. This is what you learn in the beginning when you leave dental school. After dental school, every dentist should be able to treat a tooth. Funnily, I've learned that there are countries where in dental school you don't work at the patients at all, and first they work as assistants. And I think that's a really a flaw in that system, because we in Germany, we already worked a lot on the patient and did our own dental lab work. And that you learn quite well in Germany when you leave dental school, how to prepare your cavity, how to put your contacts right, how to insert your material and adjust occlusion, and then you can treat a tooth. So the dentist in Germany is called the tooth doctor, and that is a little bit misleading, because actually we are not the doctors for the single teeth. As a dentist, we are the doctors for the whole mouth and the whole jaw and the stomatognatic system. So to master single teeth, you need to know some materials, some little bit of biology. Even if you are able to do the finest ceramic inlay in a single tooth, that doesn't make you a complete dentist. I see a lot of cases presented online or in articles or on congresses, single tooth restorations. Okay, I admit sometimes the single incisor is the most difficult challenge from the aesthetic part, but to make a good restoration in the single molar or premolar is important. It's the basics, but it's not everything that there is in dentistry. So what's missing? We also need to take into account the muscles that suspend and steer and move our jaw, the joints, the temporomandibular joints, and the complete occlusion. So these three parts constitute the main aspects of function. And then also there is the area of aesthetics. You can restore a tooth without regard to aesthetics. Put a metal colored crown on a discolored root canal treated tooth, or you try to make it really look like a natural tooth does. And in the end, there's also the patient. On every tooth, there is also a patient attached. We don't treat only phantom heads. So the whole patient psychology and the interaction between people is also a big part of dentistry. So these areas are also important for single tooth restorations. It's not so that if you treat a single tooth, you can forget about the others, because there also might be patients who are very critical on the color, about the color of a single tooth restoration when it's in a visible area. And there's also maybe you already encountered these examples, that you treat a single tooth and suddenly the whole occlusion collapses, because this single tooth was the last one which somehow kept the whole system in balance, a very fragile balance compared like two balls sitting on top of each other. Somehow the patient copes with that, but then you take away the one critical contact or tooth, and suddenly the patient gets problems with his joints and muscles, and nothing is good anymore. So it's really important also to know about these things if you treat only small cases. But of course, it is absolutely necessary when you go into bigger cases, full mouth restorations or quadrants, or even only an anterior segment. Then you need to respect also these areas of dentistry. So comprehensive dentistry respects all these areas and I want to walk through these areas with you. Of course, that's possible only very superficially. I could talk a week about function, I could talk 5 days about aesthetics, and so on. These are really huge areas, and I just want to, actually, I want to motivate you or open your interest to also, if until now you weren't so interested in these areas, to also maybe concern yourselves about these aspects of dentistry, which in the end make dentistry really interesting and also motivating you to go on. So let's start with the patient. You saw in these areas, the pink one is the patient. So I would say every patient that comes to us, especially new patients that come the first time to you, it's really important that you understand who you are dealing with, because the patient has, I would say, 4 main areas of concerns that he comes with. And what are these 4 components? First, of course, it's a dental component. He comes to the dentist. He doesn't go to the urologist or some other doctor. So there he went into the right door, because we can help him with dentistry. But also there's a big area, I would call it emotional, not necessarily psychological, because of course the psychology is also in there, but emotionally is a little bit more broad and more general. It can also be positive. Maybe a patient is happy to see you again, or did fall in love with the doctor. Everything can happen there. But what makes difficulties for us, or what really makes our life hard, is when it's negative. Patients are afraid of something, or they're unhappy. They have some problems with them. In the times we live now, most adult patients around 40 or 50 years of age, they have still living parents, 80 or 90 years of age. And those maybe are in some home and need to be taken care of, and are in a process of getting more ill and ill or dying. And these patients come to you with some dental problem and carry this huge load and these concerns and their problems with them. And you start talking about root canal treatment and this material and that super method, and maybe don't realize that it goes here into the ears and on the other side out of the ears of the patient, because he doesn't really listen, or maybe he shortly listens but goes out of the office and has 1,000 other problems. So I always try first to talk a little bit with every new patient to see if there is some problem in this area, or if it's emotionally stable. The third area is financial. It's always an issue. So at least here in my country, patients very seldom come and say, I just won some money in the lottery and I want the best, and I don't care if it costs twice the regular price. I pay you 3 times the regular price because you are the best, I want the best, and just give me the best. Usually patients want the best quality or better than average quality for less than average money. They want to make a deal. It's normal. Everybody wants to get a deal when he goes to vacation, and nobody wants to be the stupid one who spent too much on something. So at least in my country, people are very critical, very suspicious. Is it really necessary what he tells me? Does it really have to cost so much? And I see a huge problem if in our area in dentistry, where we have a monopoly, we have to be aware, we have a monopoly. Patient cannot come anywhere else than to the dentist if he has a dental problem. So I see zero reason to try to somehow underbid or reverse auction or lower our prices. Why should a good dental treatment offered for less than it's worth? We should stick together and for good quality work keep our prices high. And so anywhere the patient goes, he hears this is good work. If you want something of this quality, that is what you have to pay for it. So I have really a problem with dental offices that do special offers and try to offer something for less than it's worth, because then the patient believes it's also possible for less. And the fourth area, it's not the most critical, but you also know these patients, is time. You either have the important manager guy who, of course, everything is more important than going to the dentist, and but of course there are also people who really have too little time. They have too much to take care of, and they actually don't have time to go to a doctor, which is sad, but of course you know that. And the other type are usually the ones without a plan, who are unorganized, completely always distracted, always come too late, forget your appointments, and that also we have to cope with. So with these four areas, we somehow have to deal. The patient has these four issues, and I, as a dentist, I have my dental competence. Hopefully I can cope with the problem the patient comes with. My competence should be bigger than the problem. And it's important to recognize if the patient's problem is bigger than your competence. So then you should refer to a specialist or say, I don't have experience in that. It's never done this. It's too complicated. Never seen something like this. And then you should refer to a specialist. Don't treat cases you're not sure you're really able to cope with. Emotion, I'm also just a person, and I get irritated or angry if someone is really talking bad to me or about me. So we are no robots. We also have to deal with this emotional part. Then I also have to make my money, earn my revenues, enable to pay my rent and my employees, and in the end to be able to live off something. And also my time is limited, my living time and my time in the dental office. So I cannot afford to have this time taken from me inefficiently, or to sum it up, besides being a good dentist to my patient, I cannot be his psychiatrist or his spiritual counselor. I cannot be his banker or his finance guy. And also I cannot be his secretary or time manager, and also not my team. So of course we want to give the patient a service and help him with all the issues around his dental treatment. But that's limited because we are not really paid for that. So here's a paper I printed out in German, of course, in my office. I printed this on two sides of a sheet of paper and laminated it. So this is what you see is on the front, and then there is a back side which sometimes I show patients and turn it around. In the first meeting with the patient, I try to find out are there any issues in these other three areas except dental. And if the patient comes and is already too late and didn't talk in a correct manner to my team at the reception, and complains that dentists in general are so expensive, and is angry because the former treatment went bad, and so sometimes patients say this by themselves, but you can also with some specific questions try to find out and say, you know, the problem you have here, you know, you have to come about 20 times to me. It cannot be done in 2 sessions. Is that a problem, or is it possible? And if the patient says, no, it's no problem, I have time, I come whenever you ask me to come, that's good. If he says, oh, actually, no, I'm so busy and I'm going another country in a few weeks and I don't know how to do it, you have an issue there. And so with some questions you can try to figure out how it's about the finances. You don't have to talk about numbers and money, but you can mention that a treatment like this is in the range maybe of a small car, or some other thing you compare it with, and ask, are you aware of this? And if the patient says, yeah, I have informed myself about that, I know that, I already expected that, then it's fine. And if the patient, suddenly you see he hears the first time that it doesn't cost a few €100 or pounds or whatever, but a few thousand, and it's absolutely not possible, you don't need to really continue much further if you're not in your office able to provide that service for much less than the usual price. So if I see that there are too many of these issues, and I usually do this when patients they just spill it out, they come and get rid of all their concerns and think that's really important for me to know for the treatment. It's not important for the treatment, it's important to decide if I want to treat the patient or not. And then I can turn it around and say, you see, you now told me about this problem and that aggravation. So that doesn't help me, because it takes my time, it takes the time of my organization, and if you want me to concentrate on your dental problem, this is not really helping me. With some patients it's clear, you don't continue the treatment. With others, they suddenly realize, oh, I overstepped here, I stop giving all my old problems to this doctor, and sometimes it helps. So especially in the area that I'm working in prosthodontics, such a treatment only works with mutual trust. It is, I already talked about that, we need to learn about who our patient is, and the patient has to understand that he's our partner and not our customer. I don't sell anything in my dental office. I don't sell crowns, I don't sell veneers, I don't sell bleachings. So the only product, if you want to call it that is sold as a doctor, you shouldn't sell per se. It's an ethical, interesting question, how much we sell something or not. But if at all something is sold in a dental office, then it's the dentist. The dentist is the product. The patient, if you hear something, that's my dog sitting here. I'm not sure if he can be heard on the microphone. So the dentist is a product, and the whole office has it's the job of the office and your team to sell you to the patient. The patient has to buy you. If the patient says, this is my dog, I'm sure nobody should say anything against this dog, he's the best, then he does whatever you want. You propose him to do this treatment or that treatment, he will believe you, he has trust, and it's not a matter of trying to convince him about some procedure or new method or material or treatment concept. So that implies also that me being the product in my office, I'm not the best salesperson. I'm not the one who should try to tell the patient what to do. It's more that your office should see you as the one needs to be sold to the patient. That means we don't sell anything. The patient isn't a customer. A customer, he can complain, he can ask for giving the product back, he can ask for a reduction in price. That's everything rights that a customer has. Usually in medicine, you don't have these rights. You cannot come and say, I'm not happy how you made the surgery on me, I still have pain, and now I pay you less for that. And I really have a problem if patients have this setup in their mind that they are customers. And again, we in our profession should avoid everything that somehow generates the image that we sell something, or we are salespeople, or we sell products. Because then, of course, the patient on his side thinks I'm a customer with everything that a customer is allowed to do. So mutual trust means the patient has to trust me that I put all my effort, all my competence, and my concentration and time into helping him. I don't come with a hangover from the last night, and I don't do other stuff which compromises my quality of my work. That's what the patient should trust, and I need to trust that the patient will pay my bill gladly, hopefully, on time, that the patient comes, keeps his appointments, doesn't forget me, and I'm sitting here 2 hours and have the whole office running, and the treatment is a no-show. And so that's what we should try to achieve. I'm switching a little bit here. So what is the most important aim in dentistry? I don't know if it's the most important thing, but after doing dentistry now so long and also thinking quite a lot about dentistry, for me it's predictability. That is what I always try to achieve. You don't want to go to any doctor and then hear from him, yeah, this might be this condition, and I have an idea, we could try this treatment, and if everything goes well, then it will work out. You want to go to a doctor who says, oh, I know exactly what you have. I've seen this many times, I know exactly how to treat it, and if we do this treatment as I propose to you, then everything will work out fine with this and this range of maybe uncertainty, or because you shouldn't promise anytime anything to the patient. In medicine, you never know what might happen. So predictability is for me a very high matter. I really want to do only things that are predictable, and I'm always interested in everything that improves or increases the predictability of my treatments. How do you reach that? I think it's important on the basics to have good structure, systemization, and be consequent. I think a lot of not so good dental treatments come from not being really doing what you do with consequence. If you know that a certain procedure works best in a certain manner, for example, you found out for yourself that your best impressions you are able to make with double cord technique and leaving them 10 minutes in the mouth and this material and that tray and that, then you should do that every time the same. Be consequent. Don't try it this week with one method and the next week with that method, and then comes someone from a company and tells you there's a better material, try that, and then you try that. You will never be better. You don't have a baseline where you compare if you have improved. You are really going maybe in circles, and you should stick to what works well in your hands, and of course always try to improve. Kaizen, the continuous improvement, it's very important, but try to establish good structures and systems in your work. One of these systemizations, standardized or systemized dentistry includes doing it step by step. The one-step dentistry, drilling away some tooth substance or some old crown, taking an impression, giving it to the lab, and tell the technician, now make something nice out of that. It works very seldom. It works with direct restorations. There you can drill a hole and fill it up, but even in that area people work more and more in steps. They do a wax up before, they do some matrices and plan their work. So the one-step dentistry usually works only in very simple standard cases, but in the case it doesn't work, you might have a problem with that. So always keep in mind it's better to think in stepwise dentistry, stepstone dentistry. Move from one step, one phase to the other. These phases, they can be many, many different things. In implantology, it might be a digital planning, a guide, a setup. In other areas, it might be completely different things. But when you go step by step, that provides predictability, and you're always able to check on something, to modify something, to go in a little bit different direction, to rethink your process. So ideally, your work and your result improves step by step. Example, the provisional is one of these steps. A provisional, I always call it the business card of the dentist. That is a very important therapeutic step in fixed prosthodontics. A provisional shouldn't be worse than the situation the patient came with. So the patient comes with an old crown, you make a provisional which is much worse. It doesn't look so nice, it's loose, it falls out all the time, the gingiva inflames, and suddenly the dental technician now should make a final restoration which is much, much better than the patient came with. So you have to bridge a huge step to go a long way from your not so good result to the what you hope is an optimal result. If your provisional already is superior to the situation the patient came with, aesthetically, from stability, whatever, how the margins are tied, and then you go the last step to your final work, then you don't have so big steps to go, and you get some feedback from the patient if the way you are going in is the right direction. So that's a good example for how you should improve with the steps and not fall back to situations that are even worse than the step before. It is absolutely not defined how many steps you need. There are simple cases you can do with 2 or 3 steps, and others you need 20 steps because it's so complex and you need to reiterate and go another round and repeat something. So here an example for something that can be done in a very few steps. Actually just a quick partial wax up and then some ceramic partial veneers. Could have also been done with composite, but also then a quick wax up would have given predictability on how the result would look. Or a case which is much more complicated, with a midline shift to the left and an implant on the left central. So you are limited in how much you can put the midline back. Patient doesn't want orthodontics. You have a gingival line which is not really leveled, and it's asymmetrical, but this turned out during the process it does not be taken care of because there's a very long lip and the patient doesn't display his gingival line at all. And so step by step, with the first wax up, a first provisional, a second wax up, new lab-made provisionals, wax try-in, bake try-in, in the end we were able to make the best of this case that we could, but we couldn't have done that just prepping down the first situation, giving it to the lab and getting some crowns. So this allows you to maybe define a different goal in case you realize the way you're going is not really the right one. You can add additional steps if you want to find out about something or not sure if something is really okay, or maybe biological things happen, the wound healing is not as it should be, and then you need to repeat some surgery or something. You can go back, make another turn and repeat something. Very seldom, or actually never, I had to start from the beginning. So that's not usually the case, that you are so wrong that you start again. These can be prototypes, mock-ups, test phases, virtual imagings. There's a long list of things you can do which constitute these steps. What is important when you work in these steps? I don't want to read everything that is on these slides. It's actually quite self-explanatory. But you need, of course, to plan like an architect that renovates an old building. You always have to have a plan where you want to go to, and even if it's only in your head, but usually it's better to somehow have that on paper or on some scans or photographs. And then you also need to know all your options and your methods. So dentistry I regard as the methods in dentistry as a big toolbox. The more tools I know of, the better. If I know about aligners, if I know about 3D implant positioning and this and that, or surgical techniques for covering recessions, the better I can help the patient. And then you try to learn from your previous steps and then to improve in the next step. What I want to show here in this slide is actually that documentation is part of each step. You need to document what you do, able to compare to a previous situation or a previous step. And that is something that is still neglected in many dental offices. Everybody of us is now a digital full-time photographer with our smartphones. We run around and photograph everything that we see. But do you do that in your office as well? Do you take photographs of all the steps, all the work you do in the patient's mouth? Many dentists still don't do that. So what ways of documentation are there? We have our charts, usually today digital charts with some graphics where you can somehow document the situation in the mouth. We have our x-rays, we have our stone models, and more today scans. In my office the scans replaced the models about 80%, and the photographs. So the photographs, as I said, as I see it, still neglected. You should have a professional camera in your office. It's exactly as important as the x-rays, and try to document what you do, and then you can learn from your own results, improve. And yeah, so with this I finish the first half of my video, and I hope you stay with me on the second part. See ya. Hello, back to the second part of my video about comprehensive dentistry. So what is not comprehensive dentistry? It's simple dentistry. If you, for example, don't take into account the functional aspects, the muscles, the joints, and the occlusion, but concentrate only on aesthetics, the patient's wishes, and the materials that are available to you. You just prep something, make him new teeth. That is very simple dentistry. Now you might consider to do a smile design, to do some plan, take a template and plan the new smile. That is still simple dentistry. Even if you make a mock-up and a wax-up and put that into the patient's mouth, as long as you don't look into the whole stomatognetic system, this is not complete dentistry. So since a few years there's a big craze about digital smile design, and I think that's a good development, because 20 years ago nobody was interested in smile design. No dentist, at least in Germany. I had it in my courses, and they always told me that was the most boring part. We have our lab technicians, they know how teeth need to look like, so don't tell us about this. So now, today, smile design dentists are interested in, and there are digital programs for that. That's a good development. But what I'm really missing is the digital functional design, all the knowledge that there is about function that is not put into computer programs and systems. And that also will take a few years, but I hope that it will come. And of course, it's a very large field, the functional part. There's much more information and contradictory information on function than on aesthetics. As I already said, the field of aesthetics is a limited field. At a certain point, you can learn everything there is to learn. So let's look at the whole picture. Don't jump just on the aesthetics. Here's a clinical case. Of course, you might take some template, put it on top of it, and try to find out where it looks best. If you want to make some crown lengthening or not, and how you make here a perfect or an average smile that conforms to the average proportions and sizes. This template is the small 1x1, the small basics of smile design. It is of course only the frontal aspect. It does not regard other directions where to look at the patient, but this includes actually the most variables there are. So you see, it's really not that much. And to be honest, a basic smile design is not more than this. This is all you need to find 80% of what needs to be changed in a front anterior upper front teeth. It's these 6 boxes with the correct ratios, the horizontal line, the midline, and the rest is happening within these boxes, what shape of teeth or what type of teeth you use. If you got this right, or you find out what is the biggest difference from your current situation to this, then you can cope with 80% of smile design. It's not such a big rocket science. But you shouldn't jump on aesthetics only and take care of that alone, because this photograph includes or contains a lot of small hints or signs of some functional problem. It is not healthy when teeth have facets, bare facets like this. You see a lot of crack lines in the teeth. You see teeth that have moved and where a gap opened up. And in fact, this patient didn't have canine guidance on both sides, and had some balance contacts and working contacts on the back. So also these photographs, which I already mentioned, that they're very important to document your patients. If you think about yourself like a detective, you can detect several signs that give you hints on some possible functional problems. And if you know what you're looking for and look for that on the patient, you find even more. So this case came to me. She wanted some improvement on her front teeth. It's the same case we just saw. And you see that the left canine has lost its tip completely, and there was 0 canine guidance on both sides. We did some additional veneers on the canines. We had to do that on the upper and the lower because the gap was so big. We did some adjustments on the posterior teeth, but just doing 2 veneers here, or maybe 4 veneers, would have not been enough. It's more safe if you re-establish a good occlusion here again. So this is pretty standard procedure. You make a wax up, you make your prep templates, which tell you exactly how much to reduce. This is some superb lab work from one of our best ceramists, lab technicians here in Munich, Uwe Geringer. He's really good at adding these small fake crack lines, and you see the surface texture is absolutely perfect. You also see the canines, the additional veneers which we did non-prep, and that's the result, not after cementation but a week later, and it looks very natural. So this patient, she wanted a natural smile. That's the majority of my patients. They don't want a full smile makeover. They actually want that people don't notice that something has been done on their teeth, that others believe that it's their own healthy, super beautiful teeth. So we don't have so many patients here that need some bleach, opaque colors. And here you see before and after. So we tried to keep the characteristics of this case and improve on it, but not make a full change. Yeah, and 90% of what you see here is, of course, the work of Uwe. And yeah, it's important to keep in mind that there are is a main difference between function and aesthetics, that it's quite opposite. Functional problems, usually they needed time to establish, to happen. Sometimes, of course, you have some blockade in your joint, but that is then the result of some process that took many years. So these problems that develop over so long time, they also need long time to be improved again or healed or brought back. Sometimes you cannot turn back the time to the original healthy state. You have to try to find some state of compensation where the patient can cope with. Aesthetic problems you can fix immediately. You have a broken edge on a tooth. If the edge is still there, you bond it back. If it's not there, you make some nice composite work, or you make a veneer or a crown before after, and it's fixed in very short time. You see that also very often. You see a lot of cases in magazines before after where dentists can show, or dental technicians, how they very quickly could improve on a case. What you don't see so often, which is much more valuable, and you should look out for those guys who can show you that, are aesthetic cases after 20, 25 or 30 years in the mouth, because we are not interested only in results after a year. If after 3 years you have to redo the whole case again because everything has chipped, we want some long-lasting restorations. In function, you don't see many case reports or doctors who can really show you how they improved on the patient, but that is also because some other differences here. We will just go through that. Function, you don't have systematic structure. You have a lot of expert opinions, schools, philosophies. If you search on the internet, it's almost sometimes like religions, and there are not commonly agreed guidelines, not on national, not on international level. There are some groups or some experts that say this is our way of doing it, but we are far from a consensus here. And not only I say that, people who know much more about this say the same. In aesthetics, you have guidelines, you have these templates, your aesthetic criteria, and they have been studied in a lot of studies, panel studies, where people were asked, does it look better like this or like that? So we have quite good guidelines, not fixed rules. You don't have to stick to the rules in aesthetics, but guidelines that guide you, that you can check, is it better if I make my midline straight, perpendicular, or maybe is it not better? And then you can decide if you want to apply such a guideline or not. Here one example from renowned literature, Alan and Kievaskari, two Scandinavian scientists working at a specialist clinic in Jönköping about that question, and what they are studying is the question, the role of occlusion in function. And they stated it like I wrote it here. One of the central problems of the discussion is that TMD, it's a collective term. It includes a lot of symptoms. It's a descriptive diagnosis. It doesn't have a clearly defined structure. And you will find that many times when you go to courses or listen to experts on function. One guy says like this, the other guy says the opposite. Function is a vast field, endless. When you try to learn about functional things, you are a constantly a learner, a student. You will never stop learning. I don't think you can really master the field of function. Aesthetics, yes. There you are at a certain point. There's not much that surprises you, where you say, oh, never seen this after 20 years. I didn't know that about tooth aesthetics. It's a limited field. And in my experience, it's also easier to communicate about aesthetics with the patient. We have wax up, we can make Photoshop simulations, we can do a lot of things, and patients can also express themselves better. With function, it's complex, there's a lot of psychology in there. The patient tells you, I have a strange sensation here behind my ear, and how do you want to try to know exactly what's happening there? So the result of this discrepancy is that in clinical reality, in the offices and by practitioners, my feeling is that function is neglected from the general dentist. You have some specialists, some TMD centers that take care of those hardcore cases, but there is also patients in between that are neither completely functionally destroyed nor absolutely healthy, but start to show first signs of functional problems. And these every general dentist should know about and be able to detect. And aesthetics is overemphasized. Also, you see that in articles on congresses. You see a vast amount of nice teeth before, after, beautiful crowns. Look on Facebook, everybody is posting his results. So that is very simple to put forward, to demonstrate, because it's obviously some visual thing. You can make two pictures and you see exactly what has been done. And then you can criticize on that if you think you can do it even better. But a functional case, if you want to document a functional case really thoroughly, that's a full textbook. You have to write a lot of information down, and I'm really waiting for the time when we have our patients like virtual patients in the computer with all aspects, with the cone beam CT, the 3D bone, the jaw movements with a motion analyzer, maybe some muscle activities. The tools are there. What is still missing is a integrated environment where all this is put together. Some companies are working on that, those that are obviously best suited, that can integrate this, companies that have different types of devices and software for that, but we are still far away from having our patient completely in the computer and being able to document him well. And then over time, all these different states he's going through. So that's, I think, one of the reasons why so little is presented, or not many people who can show you clinical cases, treatment concepts, and then the results and long-term results and functional problems. So the functional part, it's more vague, it's more conceptual. We have to work a lot with assumptions. If patients tries to tell us how his feeling is. In aesthetics, it's really very concrete. You can take a ruler or a 3D scanner and measure to the micron if a tooth is a little bit wider or not so wide than the other one. Optical illusion is the only part where on aesthetics there's also some part of how you perceive things. So our eyes are no measurement instruments that can measure things to the micron. A lot is perception. It happens in the brain. That's an interesting part. I don't think that in aesthetics there's much room for creativity. Aesthetics doesn't have to do a lot with really original creativity, because to be creative means you create something new. We don't create anything new. We take nature. Nature has a vast range of variables showing to us. Each jaw is different. Teeth are like faces. Every front central incisor is a small face in itself, and we need to understand that and to understand the plentiness of nature or of God, or how you want to call it, but you don't need to be creative. Forget about creativity when you think about aesthetic dentistry. So how did I find my entry point to function? I would recommend to everybody to go to good courses, if you find those, and I'm sure in every country you have that, on how to make splints. Treatment with splints for patients who have muscle problems or joint problems, because there you can practice function, you practice it often, you practice it daily, and you learn from each case. For me, the main revelation or understanding of all these functional part was when I realized one thing, which I want to show you here, because I was standing in front of that like the rabbit in front of the snake. You don't know where to start with. Everybody is talking so much about it. It's obviously a very complicated, difficult thing. And as a young dentist, you think, yeah, where should I start with it? So my original understanding, and as also I was taught in dental school and read it wherever, was that you go like the doctor is taught, you diagnose and then you go your way to the result. So what you see here on this slide, left is, it's a timeline. Left, the patient comes into your office, and on the right, he's going out of your office. So in the door comes the healthy patient, who obviously everything is fine. He goes out of the door on the right side, no treatment necessary. Another patient comes with some findings or some pain or some problems. There's some necessary treatment, either obvious or you diagnose it and you do your restorations. It goes out of the door. And then you have those patients who have acute functional problems. Come in and I cannot open my jaw anymore, or I have so headaches and pain. These are rather seldom. Very seldom patients with acute functional problems will come to your office. So if you didn't learn about how to deal with those, there are the specialist clinics you can refer them to and say, okay, this is out of my range of competence. Go somewhere else where they know what to do with you. So, and in case you have a patient you need to restore and he has signs of some functional problems, as my joint is clicking, or you see a lot big abrasive patterns in the mouth, then how do you deal with that usually? Do you do some analysis? Will you restore him? You say, no, it's too critical, I won't restore him. I ignore it, it always went well. I can also restore an abrasive or a patient who has some problems. So that's the first area of diffuse area with a question mark. The standard procedure is, at least as we here in Germany were taught at the university, you make a so-called functional analysis. There are sheets of paper with a lot of questions and a lot of boxes to check, and you make this functional analysis on the patient, rather extensive, a lot of diagnoses and symptoms you can find there, and that is already one of the first problems. It's very many symptoms and possible diagnoses, which again multiply in the square, so you have thousands and 10,000s of combinations of these things you are looking at, and each one is different, and they might be not conclusive or contradictory, and you need to have a lot of experience. I've seen a lot of cases to be able to put that in the right box and in your system and understand what's happening there. Even if you master this, if you are good at functional analysis and do this a lot, because maybe you were at a university where you were in the guy dealing with all these patients and you are practice in that. Here's an example for one of these sheets as they are used in Germany. There are different ones. There's actually no standard on this. You can do your own. There's not a commonly agreed on functional analysis, at least in Germany. And you see a lot of checkboxes. And this is Stone Age, again, where we need to somehow document a complicated, multidimensional state of the patient with muscle tension, with history, with feelings, with perceptions. The patient has maybe some vertigo, or with the eyes, or something in the neck. And until now, what we do, we make this like a machine-readable card. We put checkboxes there and try to reduce this to a binary system. Even if you master this and are able to put the right checkboxes for all the findings you have, the next problem is you have to be able to read this again. After 2 years, you take this paper out and you try to understand from this piece of paper what state your patient was in 2 years ago. I think it's quite a task to learn that. Now, even if you are good at this, there comes another step. How do you treat the patient? The therapy. What type of splint? Look into the internet. Just type in Google occlusal splints types, and you will see how many different types of splints there are. Like every dentist who is looking for fame invents his own splint and puts his name on it, because he's the one who found out which type of splint works better. And then there are commercial companies who sell you some deprogrammers or type of splints with their brand name on it. So there's a really big variation on splint types and how you could do them. And then it doesn't end with the splints. Do you need physiotherapy? Do you need other doctors, interdisciplinary network of ophthalmologists, of psychiatrists, of orthopedics? The field is vast, as you see. And then the big question I'm always asked in my courses, how do I, even after successful splint treatment, now how do I go into prosthetic work? How do I transfer this new situation, especially when the vertical dimension is not the same than on my splint? I need to change my vertical dimension again. So yeah, this just I tell you so you understand the size of this field. And yeah, so looking at it like this from left to right, it looks in the beginning, when you don't know much about it, and for me that was many years like that, and that's why I was not motivated to start with it, because I thought, when will this end? How much will I have to learn here, and who can teach me this? It's a jungle that you are looking at. And the interesting thing is that at some point I know a guy who's a really experienced functional therapist here in Germany, and I realized he doesn't do 20 different treatment concepts and 25 different splint concepts. Basically, most times he does the same. And that means there are not so many ways through this jungle that work really well daily in your practice. So turn around. Let's look at the problem from the result side, from the right side. What we want to do is help our patients, to restore them or not to restore them, and to help them. And how many pathways are going there to my result? So I don't look suddenly into a jungle with a myriad of possible paths. I look backwards to those pathways that are proven and can work. So let's turn this around and look from behind. When I do a restoration, I can either do it directly. I don't change anything on the patient. I don't change occlusion. I don't change the position of the mandibular or anything in the surrounding structures, or I change them. And to change them, I need some methods, and that is the splint and or occlusal repositioning veneers, which are something like thinner splints placed permanently into the mouth, much thinner, and more like a 24-hour 724 splint the patient cannot remove. He has to bite with it, he has to chew with it. They are not so perfectly in their anatomy like teeth. For me, that is something in between a splint and the final restoration. So I don't make them really with cusps and all the contacts. They are simplified. But they are the step in between the splint and the restoration. And there's not much else. You shouldn't go from one situation and change the bite and take a bite registration and give the patient a new bite and then start with some adjustments. So it's the splint. Of course, before doing a splint treatment or repositioning equilibration treatment, we need this analysis. We need to gather data. So in these cases, we do this functional analysis. For the acute patient, there is also the possibility just to do a quick first preliminary diagnosis, and he's like a pain patient. I don't have to make a full functional analysis to find out about what happened here. Usually that's also not possible to understand everything. Sometimes you can help these patients with some medication or an equalizer or some Intera splint. You are building them quickly, or your lab makes them a splint until the next day, or you refer them to the specialist. The main point in this is actually what I show you my system, how I work in my office, and the central point is the screening. With the screening, you decide if those patients who come in your door, they can be restored as they are, or they need some maybe equilibration or change of the occlusion, or you want to make a splint to find out if that is necessary, how the patient reacts on that. The splint is a large part also a diagnostic tool, not just a therapeutical tool. During the splint treatment, when you work with a patient, during the next weeks and months, you find out how the patient reacts on that, and sometimes the patient stays in exactly the same position he came with, but then you know it. Then you know that you are safe not to change the occlusion. But more importantly, the screening is for those patients that you might believe they are healthy, they come without any problems. You make your regular checkup, you look on the teeth, no decay, everything fine, goodbye. But if you don't screen whether this patient has some joint problems or some muscular problems or some habits or parafunction, if you don't even ask for that, then you will not find this out, you will overlook that, and you might have a patient that develops problems soon, and you could have discovered that. So in this system, it's still possible to at any point refer to someone who is more specialized in this area, but this is a concept that works very well in every daily practice. You don't have to be a specialist on TMD to implement the screening in your daily work. And you see that these are not so many pathways anymore you walk. You do the screening on every patient. Some of them you don't treat, some of them you can restore as they come, and others you do your splint therapy and your occlusal repositioning veneers and then restore them. Or not restore them, just let them have the splint. And the more often you go along these paths, they get wider, you get more sure, more safe in what you know, what you talk, and every patient feels that. When you talk to the patient, they feel whether you tell them something you are not really safe at. If you did 5 implants in your life and then try to tell the patient that he needs an implant treatment, you will not be so successful than the guy who did 5,000 implants in his life and knows exactly how to talk to them. And this experience and routine you need to acquire to be competent and authentic and successful in front of your patient. And when you do this long enough, you will realize that also this is such a complicated field with so many different combinations, which is what makes the whole thing so difficult, because they are very. It's still so. I'm no expert at function at all. I wouldn't say that. I do this whole thing to make my prosthetic work more safe, to have less. As I said, predictability. I want to have less fractures and unexpected problems with my ceramics. So that's the reason why I implemented this functional concept in my office. But still, when you are looking out for these things, there might come a patient even after 20 years who has something that you have never seen before, where you stand there scratching your head and say, what is this? How can this be? I never heard that something like this might also happen. So that is what makes it so difficult to get into it. And every patient is very individual there, but clusters exist, fortunately. There are certain combinations that you see more often, that happen somehow, that are more connected. Just 2 examples for that. Quite frequently you find posterior infra occlusion, meaning that the shimstock will have no contact on the posterior teeth. Different reasons, maybe some large bridge put in. So this you see very often after dental work. Adjustments were done. Patient has problem with his muscles, his joints. Something does not right. Okay, reduce again, and at a certain point there are zero contact anymore, only contact in the front, and that is then gives you some lateral vector on your temporomandibular joints, and your muscles have to cope with that, and they get tired, and so this is something to look out for. Sometimes this is hidden, this posterior infra occlusion. The patient still is able to put his teeth together somehow with a big force, or maybe with front teeth that can be moved a little bit because it's maybe a perio case. But in fact, if he would wear a splint and everything relaxes, and the joint also moves out of its posterior position, suddenly there is a real big infra occlusion. Or another cluster is because the whole stomatognatic system is not a mechanical system, it's a cybernetic system, very finely tuned and steered by our nerval system, and some neurological misguidance. The patient does have no coordination. Dynamic interferences on the posterior teeth, you find them very often. No canine guidance, which is what I'm always looking for to give my patients whenever possible. Some posture problems, so plus stress. That is something that you find quite commonly. But there are dozens of other clusters like this, and yeah, it's really worth to, as a dentist, as a doctor, as a medical doctor, to learn more about this. So this means that I screen all of my patients. When a patient comes in my office, I don't look first into the mouth. First, I talk with the patients, as you saw in the first video, to learn more about the person. Second, I do this screening, which most of it is also extra-oral, and often patients say, are you the first guy who looks at this? And yeah, nobody ever before asked me about if I'm clenching or have some problems. And I promise you, you will find findings, and that is the reason of screening, to find those patients that otherwise you wouldn't have detected. And this screening I did not invent. The screening I do is based on a colleague of mine here in Germany, Oliver Ahlers, together with Jagstadt, who is a professor at the university. They did a lot of research on this and studied a lot of literature. It is six variables, 6 points you are looking at. And they found out that if one of this is positive or 0, then it's rather unlikely that there is a TMD problem. If there's 2, so CMD is in German basically the term for TMD. So if this is original German publication, that's why it's CMD. If it's 2 or more, then it's likely, but if it's more than 3, it's extremely likely, something like 99%. And these findings I will explain to you in a minute from top to bottom. Those in the beginning on the top, they are rather seldom. You don't find them so often, but those at the bottom get more and more common. So you're looking, let's go through them one by one. If the opening is asymmetrical, you ask the patient, please open wide, and you just sit behind him and see if there is a deflection to one side. A deviation where it's like an S-curve, it doesn't count, but only if one joint is limited, doesn't move so far, and the whole jaw moves to the side. You can take some grip of your instrument or some ruler, but usually you see that quite well with your eye. Takes half a second. At the same point, as you ask the patient to open as wide as he can, you see if it's a limited opening, if there's a limitation. And the rule of thumb is 2 fingers. I always take my own fingers. If I can put them in the patient's mouth, everything is fine. If it's less than that, then there is some limitation. Then you are looking if there are clickings of the joint. not a stethoscope. This is a screening. This is not a thorough examination. So usually you can better feel this with your fingertips, palpate it. So you ask the patient to protrude. That's the best movement to provoke a click. Let the patient protrude, feel it, ask the patient if he hears something or feels something, and here it starts to become more common, as I said. To the bottom you have the more frequent findings. So clicking in the joint, then occlusal noise sound. By that it's meant how the teeth sound when you hit them. So you ask the patient to hit his teeth. And then everybody has to be quiet in the room, and you ask the patient to make this so that you can hear it. And then it should sound, as you just heard, a clear, hard sound. If you hear something like juk 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 or oomph, not really a hard sound, something is off. You have some premature contact, some sliding contact, or something is not right, and you know that. It's just a screening. You don't have to go deeper in here. You just want to know how many of these check boxes you will have. Next, you go into muscle palpation. Alas does this on masseter, temporalis, and digastricus. I do it only on masseter because that's something like the 90% muscle. So if you have something here, you don't need to look at the others. And if you have nothing in the masseter, you don't very often have something, especially in the temporalis. That's more in hardcore cases that you have pain here. But you can also check all three muscles. And the interesting thing here now is that when you do this, you start to become an expert in masseter palpation. If until then you never did it, or maybe did it once a month when you did a huge functional examination, then you never learn about how the muscles should feel. The best guys to look at muscles are the physiotherapists who treat patients 8 hours a day, every day. They feel 100 times more with their fingers than we do. But if you now start doing the screening and palpate the muscles of your patients, your fingers start learning, and you start are more and more able to discern small trigger points, what is a hard muscle, what is a soft muscle, and you get expertise in that. And I do that daily several times on all my patients, and by that you get a good diagnostician, or you are good at diagnosis, but only on this small area of masseter. And in the end, now with the and this is quite frequent, you find this on many patients, and it's not normal, it's pathological. A healthy muscle, if you push your biceps, it doesn't hurt. So if a muscle hurts at palpation, something is not right. And in the end, you look at occlusion and check for traumatic eccentric contacts, meaning lateral occlusion left, right, and you check if there are balance contacts, some posterior contacts, and can note those. I do that usually with a plastic foil here, where you just check whether the foil gets out easily. If there's a canine guidance that discludes your posterior teeth, and you can take out your foil. But in case you have some dynamic contacts there, like in this case there are balance and working side contacts, and you get some holes or some color is removed from your foil, you can show this to the patient and tell them that this is not how it's supposed to be. So I have this in my practice management program, and I added a few questions, because if you ask the patient 5-6 questions during you do this, you gather even more information. Or as the patient is sat down on the treatment chair, I already asked this, or my assistant asks the questions. So you don't have to, like a detective, find out about something you don't know if the patient maybe can directly tell it to you. So I added some questions. You can modify this as you want. So usually we wrote some more stuff there, and the longer this takes you, the more obviously you have found. So it doesn't matter. Usually this takes 2 minutes, If the patient is healthy, then you are safe, you have done it. And the moment you find something and find more and more, you can of course ask some more questions, because these patients, usually I recommend a splint treatment, a more extensive functional analysis, and many patients are grateful for that. So that was some basics about function, and to finish this, I would just like to add a few more comments on practice management. As you saw, that is also something that is part of our profession, except you're working at some university clinic where you don't need to take care of anything, just your patients, but usually in a dental office you have also the role of the office owner. So if in on a party someone asks you, what is your profession? You would obviously say, I'm a dentist. And that is true, except when in your own dental office you have 20 other jobs or professions, or maybe even 30. And these are all professions that you can study, you can learn, you are taught. So a controller, he goes to courses and to schools to learn that, or a marketing expert, or an HR expert. So we in our small offices, we do all this just beside our regular work. In Germany, dentists work 3/4 at the patient and 1/4 they do administration. So 25% of their time they do 20 jobs, and to me it's obvious that we are all amateurs and dilettante at this. We make mistakes. How should we be able to do this really professionally if we do so many jobs we never learned and somehow have to teach ourselves or ask our colleagues, how do you do this? And I see that really as a growing problem with all the administration and all the rules and regulations we get. They are always increasing, they are not getting less, and this will not improve. I think in the future this will be more and more severe. So everybody has to find for himself how to deal with this personally. Now, one of the big issues or problems here is that the dentist and the office manager are extremely contradictory. There are not just two jobs, but there are very opposite jobs. They require from you opposite setup of your mind. If you look at the personality profile of the expert, a dentist who treats patients is by definition an expert. And the manager is exactly the opposite of that. The expert, he likes to do it himself, and he does it himself. So we all polish our fillings and drill our holes, and in the moment you delegate this and give it to your junior assistant or some other dentist, you think, oh, what if he doesn't do it right? And many experts are a little bit of control freaks, and that's a personality trait of an expert. He doesn't like really to delegate, and I'm also more the expert type. I do all my provisionals myself all my life, and I also will not change this. And other dentists come to me and say, you are stupid. And at the time my assistant makes a provisional, I drill 2 more teeth and I make more money. But simply for me, that's a too important part of my work, and I want to do it myself. That's just an example. Manager doesn't do anything himself. That's the definition of managing. Definition of managing is to take care or to do what is necessary, that everybody else does what he's supposed to do. But the manager doesn't go there and drill a hole or fix a car or do something. So he leads, he manages, organizes and delegates. Completely the opposite of the expert. The expert is focused. You know, the endospecialist who can look 8 hours straight through his microscope with here not looking left, looking right. The manager is the opposite. He has to look what happens in other countries, what happens in other cities, in other branches or other companies. He has to be open-minded, look outside his field of expertise. Expert needs evidence, his scientific mind. You know always these questions. If someone shows some new method, is this evidence-based? There are even, here in Germany at least, as a society, a scientific society for evidence-based medicine and or dentistry. So we need our studies, we need our proof. A manager is completely the opposite. He doesn't need any proof. If the manager of some top company decides out of his guts that it might be a good idea to acquire another company, he will ask his team afterwards to fabricate the scientific proof and the data that his decision was right. But they don't go into numbers and studies, and a lot of management happens through intuition and empirical experience from the past. For an expert, his social competence, his character, is not the most important thing. If you if you break your leg and need some very complicated surgery, you don't care if that surgeon maybe is an idiot and you don't like him. If he's the best surgeon in your area and you say he's the guy who can fix my leg again and I don't see him ever again. The manager, he needs exactly the opposite. He has to be able to connect to people, to lead his staff, to be able to talk in the right way to partners and or the people he's working with. And in the end, for the expert, efficiency is secondary. The moment you do some clinical work, for example, you make a filling and you have the bubble in there, and you polish it and the bubble opens up, and you know exactly that after a few days the dark stuff will be visible in that air bubble, you are not happy. You want to fix that. You want to remove the bubble and fill it up or replace the latest layer of your filling. The manager, for him, efficiency is everything. So he is not happy if you take 2 times that it was planned for your filling, because he knows exactly that no money is made there. Now, the big problem is that we dentists in our own office are both in one person. It's like Dr. Jekyll and Mr. Hyde. You have to switch between this all the time. As a clinician, my book with the appointments, my calendar, is always too full. I would like to have half an hour more for every patient to be able to talk to him, to really make the best service I was able to. But as a practice owner, my schedule is always too empty, because I say, oh, there's half an hour. I could squeeze something in there because that is some revenue or lost. And you're really torn between these 2 extremes in your daily life. Just imagine you're sitting in at the patient, you're in the flow, you do some nice work, and the door opens up, and someone from your office comes in and says, the lady Miller, she is complaining because she's waiting already 20 minutes, and the insurance called, they won't reimburse that patient, and our other assistant, she just called in sick. You don't want to hear about that. You say, don't bother me with this shit. And in the other side, when you organize your office, you are in your team meeting, you work on your Excel charts and try to do everything right as a practice manager, and then someone comes in and says there is an emergency patient down there and he needs immediate treatment, then again you say, no, I cannot really use this now. And this you have every day, several times. You go into your office, you go in treating patients. So I don't have a solution for you here. I just want to show this up because this helped me a lot to understand this. You can try to separate the times for this, to make practice management only on 1 day or 2 days in the afternoon and no patients then, and not try to mix this up all the time. You can also, I did that, I made up signs, do not disturb, on my office door and also on my operatory and where I treat patients. So you try to reduce these unexpected disturbances, because of course in a small office you are there for everybody, you have an open ear for everyone, you want to be a good boss, everybody can come to you with his concerns. But if you are in your head with a complicated case and try to figure out some medical stuff, and then your employee comes and says, it's really urgent, I want to know about my vacation, which I have in 6 weeks, but I want to know it today, that's not really helping us. And I think most of the stress we have in our dental offices stems from this discrepancy here. And yeah, I hope that I could start you thinking a little bit maybe. If you have questions, you can write me an email. I just see I didn't put my email address here, but that is simply Hajto at hajto.de. So the first web address you see there, hajto.de, that is the internet page where I have my courses and the links to my publications and books and everything, but that is mainly German. And if you put my name again in front of that, Hajto at hajto.de, then that email will reach me. If you're interested in my anteriores work, the front tooth system, which is now more and more widely used general system for tooth shapes, then you find all the information on the next two websites. Dental Team Hajto.de is my practice website of my dental office. If you want to do me some good, then write me some good Google rewards, 5 stars. We all need those, and I will also give that back to you, of course. We can help each other there. And the Ptfe Cord.com, maybe you might want to check that out. I didn't mention that here. That is a Teflon cord that I use, which I'm really happy with. And it's not a dental product, it's a generic product, but you might want to try that as a retraction cord. And finally, on Facebook, I can be reached quite well. That's how Adam Nalty contacted me. And now I hope you didn't fall asleep. I talked too much. And yeah, I'm open to any questions or suggestions. And thank you for your attention.